Welcome to The Explainer. Today we're going to dig into a powerful new force in medicine, one that promises to completely revolutionize how we treat disease. But here's the thing. It's also hiding a pretty dangerous secret, one that reflects the deepest biases of our own society. We're talking about the algorithms that are learning to make literal life or death decisions. Artificial intelligence is just exploding across healthcare right now. You're seeing these tools pop up everywhere, from the simple risk scores your doctor might use, all the way to really complex AI. And the whole point, the big promise, is to personalize medicine, predict diseases before they even happen, and save lives by making care way more efficient and precise. So, is it learning our worst habits? Well, that's the million-dollar question. And a really groundbreaking paper from BMC Medicine shows that, there's a huge flaw here. It turns out that if we're not super careful, these incredibly powerful algorithms can actually inherit and even amplify our own societal biases. And that can lead to some seriously unfair and honestly dangerous outcomes for the people who need our help the most. Okay, medicine's double-edged sword. Let's really dive into how this actually happens. Because to get a handle on the risk, we need to look at a real-world case, a situation where an algorithm, designed with the absolute best of intentions, just went horribly wrong. So check this out. An algorithm was built on what seems like a simple, logical assumption. The more money spent on a patient, the sicker they must be. Makes sense on the surface, right? But here's the problem. Because of systemic barriers, Black patients often have lower healthcare costs, even when they're just as sick as white patients. And the result? It's pretty shocking. The algorithm systematically recommended less care for them, reinforcing the exact disparity it was meant to help fix. So how does this happen exactly? It's what the researchers call a vicious cycle of bias. They have a term for it, trickle-down bias. And it's basically a process where all the inequalities that exist in our world get baked right into the software, right into the code. I love this analogy. A biased algorithm really is like a recipe with bad ingredients. Think about it. You could be the best chef in the world with the most advanced cooking techniques, but if you start with spoiled ingredients, what are you going to get? A terrible meal. It's the exact same thing with algorithms. If the data we're feeding them is already biased, then the results that come out the other end are going to be biased too. Garbage in, garbage out. And this right here, this just lays it out perfectly. You can see how this bias becomes a vicious, self-perpetuating loop. It all starts with a bias that already exists in society. That inequality then totally skews the data we collect, right? It gives us a warped picture of reality. Then, we build our fancy algorithms on top of that bad data. And what happens next? Well, those flawed algorithms start making unfair healthcare decisions, which then, you guessed it, reinforces the original problem in society. It's a cycle that just feeds on itself. Okay, so let's look at a really concrete example. There is this calculator, a tool designed to predict how successful a vaginal birth after a C-section or a VBAC would be. And originally, it actually included race as a risk factor, so it predicted worse outcomes for Black and Hispanic women. But what was really going on? The algorithm was confusing socioeconomic barriers, things like income, insurance, access to good care, with actual biological risk. It got them completely mixed up, and because of that, it ended up steering non-white women towards more C-sections, a really major surgery, all based on a fundamentally biased assumption. So, when good code goes wrong, let's get into the two main ways these algorithms can actually fail us, because sometimes they can look like they're working just fine on the surface, but they're not. The big goal here is something called algorithmic fairness, and really all that means is that the tool, whatever it is, should work equally well for everybody. It should give you reliable, equitable results for all patient groups, no matter their race, gender, or where they come from. So what does it actually look like when an algorithm is unfair? Well, the research boils it down to two big problems. The first one is unequal mistakes. This is where the algorithm just messes up more for one group of people. It has way more false alarms, or even worse, more missed cases for them. The second problem is unreliable predictions. This is super tricky. It's when a 20% risk score for you means something totally different than a 20% risk score for me, just because of our demographics. And this chart, wow, it just visualizes that first problem perfectly. Let's imagine we've got a model that's supposed to predict diabetes. Okay, look at the bar for the privileged group. The model only misses about 5% of future cases. Not bad. But now look at the marginalized group. It misses 15%. That is 3 times as many people who are just not going to get the preventative care they desperately need. 3 times. And listen, this isn't just some hypothetical thought experiment. This quote points to a really shocking, real-world finding. Think about the standard age guidelines for when women should get mammograms. That's a simple algorithm, right? A set of rules. Well, it turns out those rules are so misaligned with the actual risks for Black women that to make it fair to get the same detection rates, screening for them should start a full 10 years earlier. A decade! That's just staggering. Okay, so towards fairer healthcare. After hearing all this, you might be thinking, should we just scrap these tools altogether? It's a fair question. But the paper actually argues, no, we shouldn't. Instead, it lays out a clear path forward for everyone involved. Clinicians, developers, and yes, for patients too. The solution here isn't to just throw out the technology. It's to engage with it way more critically. And as you can see here, it's really a team effort. Doctors and clinicians have to really dig in and evaluate these tools, not just technically, but ethically. Developers, they've got a huge responsibility to be transparent about how their models work. And for the rest of us, we have to help build a culture where fairness is something we can all talk about openly, doctors, data scientists, and patients together. Now, one really powerful tool to help with this is called counterfactual fairness. I know, it sounds super technical, but the idea behind it is actually pretty simple. It's all about testing an algorithm by asking it tough what-if questions, like, hey, algorithm, would your prediction change if this patient's race was different, even if all their medical info stayed exactly the same? It's basically a way to go on a hunt for those hidden biases. All right, final section. What do we demand next? Because this isn't just a problem for data scientists in a lab or for hospital administrators. This is about us. As patients, every single one of us has a stake in making sure these incredibly powerful tools are used the right way. We have to keep this in mind. The whole point of personalized medicine is to treat everyone's unique needs. It's not about treating everyone the same. In fact, in a world that's already full of inequalities, treating everyone the same can actually make things worse. True personalization means really looking at each person's individual needs and circumstances and tailoring their care to that. You know, at the end of the day, this all boils down to one thing: trust. We as patients have to be able to trust that the advice we're getting, even if it's AI-assisted, is fair. We need to know it's based on solid science, not some hidden bias in the code. And that kind of trust, it can only happen if there's total transparency about how these big decisions are being made. So here's the bottom line. AI doesn't have to be biased. These tools have so much potential to help us, to improve all of our lives. But they will be biased. They'll just be a reflection of the inequalities in our world, unless we demand better. All of us, clinicians, developers, and especially us as patients. So the next time a big decision is being made about your health, maybe it's worth asking the question, how exactly was that conclusion reached?